Hello friends, I am Dr. Sourabh Patwardhan from Nandadeep Eye Hospital PG Teaching Institute and FECO SICS Training Center, Sangli, Maharashtra, India. In our center, we have a lot of teaching activities which includes hands-on training as well. In this video, we'll be seeing a case done by the surgeon. This is a case of soft cataract, and I would like to highlight few common mistakes which the surgeon can do in tackling soft cataract. So the Capsulorhexis is being made using a forceps, and for soft cataracts, remember we should always avoid very small rhexis, because if you want to do either hydroprolapse or phaco aspiration, if you are in trouble, then if it is a very small rhexis, say less than 4.5 millimeter, it is going to have trouble. So that is one good thing the surgeon did here, is that the rhexis was of good size, around 5 millimeter. And here I want to show you that though the hydrodissection was done, you can see the wave now. The nucleus was tapped on the same side from which the fluid was pushed. So ideally the surgeon should have pushed the nucleus down or tapped the nucleus down from the opposite side, so that the fluid comes out from the opposite side, so the nucleus is free from all sides. So here the nucleus is free from the part which is on the upper side, but you can see on the inferior side of the video the nucleus has not been freed, and you will see that when the surgeon tries to rotate it further, the surgeon will have difficulty. Now even the depth of the trench is okay only in the superior half, but in the the half which is closer to the phaco tip, you can see that trenching is not deep enough. And now the surgeon is trying to rotate the nucleus, but because after hydrodissection the fluid didn't pass completely 180 degree, you could see that in that area the nucleus is still stuck, and there is always a trouble. So you have non-rotating nucleus and the nucleus which is not divided completely, and that's why now the surgeon is having fluctuations in the anterior chamber, because the surgeon is trying to remove the entire nucleus which is not divided completely and still not made smaller in size. So fortunately here the surgeon stops and decides to repeat the hydrodissection, but as the hydrodissection is repeated, you can see the hydrodissection is still not complete and the iris tries to prolapse. So probably that's why the surgeon is little bit cautious to push more fluid, and hydrodissection remains incomplete, though the surgeon felt that hydrodissection is done and now tries to rotate the nucleus, and the surgeon cannot rotate it because the hydrodissection is yet not complete. So what to do next? So surgeon decides that it's better, because it's more like a bowl now, I will try some visco-dissection if I can prolapse. So on one side it doesn't happen, on the other side he pushes the visco into the bag, and you can see the equator of the lens on this side it prolapses out. So probably I would just rotate it further and pull it up further, but that's fair enough. And then the surgeon decides to do phaco aspiration of this prolapse part of the nucleus, which gets chopped off from the rest of the nucleus. And again probably now again there is a bowl which is in the bag, and now the surgeon tries to aspirate it from the periphery. Here the foot switch control of the surgeon is important, because if there is little bit of punch in the periphery, it might cause PC rupture. So I would advise that probably again do some more visco-dissection and prolapse this soft nucleus out again, but surgeon decides to go ahead with the aspiration, and luckily the remaining nucleus could be pulled out of the bag here. So there were several steps where probably the surgeon could have done better. You can also watch the video again and comment on what can be done in a better way. Thank you.